Great. Thanks, Marty. My name is Ruth Payne, and I am a float chaplain with Advocate Aurora. I have the privilege of serving patients and team members at our 4 area hospitals here in Milwaukee. And welcome to Friday Chalk Talk. I will be your moderator for today. So this morning we have Andrei Chernosov, who is a hospice and palliative care fellow this year with Advocate Aurora. And he will be leading a discussion about how to effectively and accurately communicate prognosis with patients and families, rather than the science or medicine of formulating the prognosis itself. Andrei hails from the East Coast, specifically New Jersey, and that's where he completed his residency before moving to the Midwest. One thing to note about Andrei is he loves dogs. He and his family have 4 large dogs, 2 Alaskan Malamutes, and 2 German Shepherds. Today's format will be in 2 parts. First, Andrei will provide us with a PowerPoint, and we ask that you remain muted for that. And then after that, we'll have an open discussion. Thank you all for attending, and I hope you enjoy today's talk. And with that, I turn it over to you, Andrei.
Thank you, Ruth. All right, so my name is Andrei Chernosov. As Ruth mentioned, I am a HPM fellow here. And this presentation will be on the pearls and pitfalls when communicating prognosis. So here we go. So this might be because of all these barriers to having the conversation, which is that, how long do I have to live conversation? So there could be discomfort in discussing prognosis, uncertainty or inaccuracy in predicting death, difficulty talking to patients or families about dying, this being even more challenging when patients have multiple comorbidities, and adoption of an optimistic or avoidant attitude in conversation. So starting at the beginning, how do we fix this? So one thing is, before talking to your patient or their family, collaborate with all the other team members and come to a consensus regarding prognosis and management options. Patients really want honest and accurate information. They want it disclosed in like an individualized way with empathy and understanding. And the information sharing should be a continuous process. If you're particularly close to a patient and are the sole provider, don't be afraid to kind of reach out for a second opinion, because like I mentioned, the better you know a patient, the worse you are at prognosticating for that patient. So this study by Lucas Zier, participants in the study identified several factors that contributed to more belief in a patient's prognosis. And if you remember, this particular study was the one that was talking about the surrogates not trusting the physicians, but things that contributed more to that trust, receiving similar prognostic estimates from multiple physicians kind of reinforced that belief. So that's why it's important to reach a consensus, and prior experiences with accurate prognostication, which obviously if physicians have been correct in the past, people are more likely to kind of have some faith in them. So another thing, surrogates' doubts concerning prognosis did not prevent them from wanting the prognostic information. So even if they didn't really believe you, they still wanted to know your opinion. Physicians' prognoses are viewed as rough estimates that are still valuable in making informed decisions. They're also viewed as a key step in preparing emotionally and practically for the possibility that a patient might not survive, because that possibility is still kind of in their heads, even if they don't totally believe it. So how do you do this? One method is spikes, which I'm sure some people out there have heard of. Setting, make sure it's appropriate and private. Perception, establish the patient's understanding of their illness. We always ask kind of the question, like, what's your understanding of what's going on? Invitation, ask permission to convey information. Don't make the mistake in assuming that everyone wants to know everything that's wrong about them. Knowledge, provide clear information in a way that the patient can understand. Emotion, acknowledge emotion with empathy and validation. and always kind of summarize and conclude with a plan of care going forward. So responding to emotion. So when you give a prognosis, frame the prognosis as like the average time a person with a particular condition lives. Use a range, hours to days, days to weeks, weeks to months. And that's something that we kind of do pretty commonly in palliative care. So discuss treatment limitations, including what treatment options do exist, just to provide that clear and complete picture. Discuss the possibilities of remissions, and discuss the general progression of the disease, so that the patient has kind of a general knowledge base about what their disease is, and acknowledge the different possible disease trajectories. Ensure that all the parties that want to be involved are present, and that the patient themselves wants these parties physically there, so that it's kind of a shared group supportive environment. Give a warning shot, and what I mean by that is don't go into the room and say, I'm sorry to say you have cancer. Say, you know, empathically, like, I have some bad news to share. Is it okay if we take a few minutes? Don't just jump right into the bad news. Be clear and simple in wording, direct, but also sensitive in the way you word things. Provide information in small chunks, basically don't overwhelm the patient with information. Make optimistic, truthful statements, which can be difficult at times, but saying something like, I'm sorry that we can't cure the cancer, but we can make sure that we manage the pain so that you're as comfortable as possible, because that's like an optimistic thing to kind of have a silver lining to that. And lots of acknowledgement and reassurance. Acknowledge, like, validate the patient's emotions, reassure them. And like I said, always conclude with a plan. Like, you know, basically, this is what we're going to be doing, just so the patient feels like there's some direction in the care that they're getting. So expect an emotional reaction. You're going to be telling some very heavy things to the patients. If the patient kind of doesn't respond emotionally, that might honestly be more of a red flag than if they do have an emotional reaction. That might mean they're in denial, or they're shutting down, or they just, you know, in some sort of shock from the news. Take the time to let the patient and the family process their emotions, because we can't process logistic information like treatment plans and medications, or make appropriate medical decisions until we being human beings have processed the emotions first. You can't expect someone to agree to really understand a treatment plan if they're still in shock from hearing their diagnosis to begin with. Make empathic statements, ask exploratory questions, and validate responses. And those last three, just some examples. Empathic statements. I'm sorry to have to tell you this. I can see how upsetting this news is. I can tell you weren't expecting to hear this. I was also hoping for a better result. Exploratory questions. Could you explain to me what you mean by that? Tell me more about your hopes, fears, etc. Could you help me understand what you're worried about? And you mentioned that it frightens you, or, you know, things along those lines. And in terms of validating responses, I can tell how difficult it is for you to hear this news. Although we cannot cure your condition, we can continue to take care of you. I can see how you might feel that way. And, you know, you have a good understanding of this complex issue. Something like that really makes the patients feel like they're, you know, involved and, you know, part of this whole treatment plan. So in conclusion, because I did promise pearls and pitfalls, and this is just kind of a nice summary. Pearls include, you know, reaching the most accurate prognosis possible through collaboration and consensus using the appropriate prognostication tools. Realize that patients want honest information, even if they don't necessarily believe you. Use spikes to communicate prognosis. Establish understanding and ask exploratory questions. And expect emotion and respond to it appropriately with sensitivity and empathy. Some pitfalls. Avoid giving a prognosis without first consulting everyone on the care team. Do not be overly optimistic for the sake of avoiding uncomfortable conversations or giving patients hope, which is ultimately false hope. Avoid burdening the patients and families with a large amount of information at once. Give it in small increments and allow time to process. And don't expect patients or surrogates to understand a treatment or care plan until they have processed the emotions first. That's kind of a, if you take away nothing else from this kind of discussion here. So this is the end. Last time I gave you a Lord of the Rings quote. Today it's a Harry Potter quote. We must all face the choice between what is right and what is easy. And sometimes it's a lot easier to just kind of avoid these kind of conversations, but it's really not the right thing to do. So if anyone has any questions, topics for discussion, these are just my references that I used. Now it's kind of open for everyone.
This is
you,
Nora.
Andre.
Thank you, Andre. I love the presentation. First of all, it's very well put and really very excellent job. I would add that usually as physicians and providers, we're usually also afraid of being wrong, most of the time when we're communicating these prognosis, even when we know the reality, there's always this thing in our back of our mind, I don't want to be the physician who got it wrong.
Yeah, and that's why we try to, I hate saying it like this way, but the kind of the way that we say things like, days to weeks, weeks to months, and we always say, like everyone says this, we don't have a crystal ball, we can't say the future. And, but I think it's more important to communicate to the patients, like, this is what I'm thinking right now. It might not be right, but this is the best information that I have.
Hey, Andre, this is Rose. Great job.
Hey.
So I think prognosis, you really also have to consider the disease states. I've actually done a prognostication presentation in regards to heart failure, which is obviously a very different thing than, say, in cancer. So I think that really discussing not just time, but also that particular disease state, that particular disease trajectory. In heart failure, we always talk about the unpredictability of that particular disease, where you are at risk of sudden cardiac death, but this could also be something long and drawn out where we may say you have a 50% chance of mortality at 1 year, and 5 years later, you may still be here. So I think it's important to really incorporate the disease process when you're talking with patients. I think that helps them to see where they are on that trajectory. And then I guess the one other point I would make is euphemisms, staying away from euphemisms. I think that that's another thing that is a super pitfall for a lot of providers. But thanks for all the information.
Yeah, no, thank you for that.
Another point I want to add, Andre, is that when I'm looking at your presentation and a prognostication, usually they're not mentioning things like we usually say, we don't have the crystal ball. It's more advocating for us to be more affirmative, have a crystal ball, we can be wrong. And I wonder what the patient really hears once we start saying that, is that maybe in their head, this just contradicts what we first said, in despite of all these tools are giving us, is trying to make us more affirmative in a way, if I'm making my point clear. What do you think about that?
It really is hard. And I think that also kind of plays into the fact that the patients might not, believe us or believe someone when they say, like, this is what I think. But it doesn't even matter if they believe us or not. If we kind of empathically and kind of clearly state what we're thinking, I think it still makes a difference for the patients. And I think they do appreciate that, even if they don't necessarily show it.
Nora, I think there's two things to what you're saying. One is that I find the I wish, I hope, I worry helpful, because I think that that is priming them that we have an emotional concern beyond the data that we're giving them. Like, what I'm seeing, I'm worried, and here's my uncertain time frame that I'm giving you. So I think you can kind of appeal to emotion and appeal to data. The other thing is that I see discussions around prognosis not as forcing the patient to know the data, but more as a priming them for kind of giving them information to integrate that, like exactly what you've been speaking to, Andre, so that they can see how things go. And as I think Rose was saying, you know, oh, I am getting sicker. I'm starting to notice these signs that we talked about, that this means that time is getting closer. So a fair amount of the time, I have patients call me up and say, we're ready for hospice now, because we've talked through what things are going to look like and when that would be the best support for them. One quick thing is, when people ask me about prognosis, I really try to point down like what it is that they want to know. If there's a certain point in time that they want to know about, because some people don't want to know how much time do I have. They want to know, will I live to my daughter's wedding? So that is a different question than me giving them that time frame, if that makes sense. Or they want to know just what things are going to look like more than a time point.
Andre, great job. Just a couple of comments. I think the idea of repetition when we're talking about prognosis is really important, because as you have pointed out, a lot of times patients don't hear everything that you say once you begin this conversation. So I think even in that conversation, reassuring people, we're going to come back to this, we're going to go over it again, I'm available for questions. And then acknowledging that this is not a one-time conversation. As things progress, as we see what happens, I'll be honest with you, I'll tell you what I believe is going to happen. I think that's reassuring to patients, because sometimes they feel like this is a one-time conversation and they're left with it and they don't know what to do with it. So just understanding that they have future conversations and we'll go over this again can be very, very helpful to patients.
This is Pam Moore. I'm a social worker at the Iowa City VA. One of the questions I've found helpful after patients have had these sorts of conversations with our physicians and follow-up is to ask the patient, again, what did they hear from the doctor? And then what do they think would be important for us as their healthcare team to know about what they want, having been given that information today? So that it gives them an opportunity to tell us what are the important values in their life now.
Yeah, that makes a lot of sense.
Yeah, that's an excellent point. This is Ruth, chaplain, and a couple of things I wanted to emphasize too that you said were when you go into the room, like even just asking is now a good time even to have this conversation, you know, like, or do we have some time, it's okay. And then being with their emotions, like you said, if we're not with their emotions, they won't hear anything else that comes. So really having that time with them and knowing that there's another conversation down the road, but also saying, are there any questions? Any questions?
Carrie, that's a really good point too in the chat, that having the captain of the ship on board, like the one physician that they trust the most, can make a big difference. The one kind of guiding their care the most tends to be the one that they trust the most. Yeah. I mean, these are all good points by everyone. Prognostication is like a really big and varied topic, and there's like lots of different approaches and lots of nuances to it. So all of these points from like this discussion we're having are really great.
All right, guys, thank you all for attending. Have a wonderful weekend, and we'll see you guys all next Friday.
Thank you. Happy Friday, guys.
Absolutely.
Thank you, Andre.
Thanks.
Bye, Andre.
Good job rolling with the punches too. What a nightmare.
Yeah, well, we did what we could.